Good afternoon all. Myself Dr. Siddharth Singh, Assistant Professor in Cardiac Anesthesia from UN Mehta Institute of Cardiology, and today I am going to discuss a very important topic, that is mechanical circulatory support in ICU. So first before going to the proper mechanical circulatory support, we will first going to know about the definition of heart failure. So what is heart failure? It is a clinical syndrome that resulting from any structural or functional cardiac defect. So the heart is unable to pump blood sufficiently to maintain the oxygen supply and demand of the body. So heart failure is a costly and potentially fatal condition. The overall around 2% of adults have heart failure, and mostly over the age of 65, and this increased to 6 to 10% now. In the year of diagnosis, the risk of death is about 35%, after which it increased to 10% each year. Common cause of heart failure is ischemic heart disease that contributes to 40%, dilated cardiomyopathy followed by primary valvular disease, hypertensive heart diseases, and others that contribute to 5%, like chemotherapy induced rheumatology, autoimmune disease, endocrine and metabolic disease like thyroid, acromegaly, pheochromocytoma, diabetes, obesity, familial cardiomyopathy or any genetic heart disease, heart rhythm related like premature ventricular contractions and hypertensions, infiltrative cardiac diseases like amyloidosis, sarcoidosis, myocarditis like infectious toxin mediated, immunological mediated, peripartum cardiomyopathy, Takotsubo cardiomyopathy, and substance abuse like alcohol, cocaine, and methamphetamine. Pathophysiology of heart failure. If you see, the heart is not pumping well. So what will happen in our body? The renin-angiotensin-aldosterone system will activate, which will increase the afterload. So if afterload will increase, heart cannot able to pump the blood forward. So there is back pressure changes, which causes congestion in the lungs, and there is congestion of the liver, then there is pedal edema, and that will deteriorate, and the vicious cycle will go on like this. So the clinical indicators for advanced heart failures are repeated hospitalization or emergency department visit, need for intravenous inotropic support, persistent NYHA grade 3 and 4, severe reduced exercise capacity, the peak oxygen requirement is less than 14 ml per kg per minute, 6-minute walk test distance is less than 300 meter, intolerance to renin-angiotensin system inhibitor because of hypotension or worsening renal function, intolerance to beta blocker, recent need to escalate the diuretic dose, mostly more than 160 mg per day, refractory clinical congestion, progressive deterioration in renal and hepatic functions, worsening of right heart failure and secondary pulmonary hypertension, frequent systolic blood pressure less than 90 mmHg, cardiac cachexia, persistent hyponatremia, that is serum sodium less than 134 milliequivalent per liter, refractory to recurrent ventricular arrhythmia, frequent ICD shocks, and increased predicted 1-year mortality is more than 20%. So in these patients, generally mechanical circulatory devices are beneficial. So what is MCS devices? Mechanical is a mechanical pump designed to assist and replace the function of either the left or right or both ventricles. Mechanical circulatory devices are indicated to provide hemodynamic support to patient with cardiogenic shock, symptomatic advanced heart failure refractory to guideline directed medical care. It decreases the workload of the heart while maintaining adequate blood flow and blood pressure. So indication for MCS is chronic heart failure with ejection fraction less than 25%, peak oxygen requirement less than 14 ml per kg per minute, NYHA grade 4 for more than 60 days, NYHA class 3 and 4 for 28 days, and IABP support for 14 days, or 2 failed attempt to wean from IV inotrope, increased diuretic requirement, symptomatic despite of synchronized cardiac synchronization therapy or inotropic dependency, and acute refractory cardiogenic shock cases like acute fulminant myocarditis, acute myocardial infarction with cardiogenic shock. This is the most common cause, acute myocardial infarction, for requirement of ventricular assist device, and postpartum cardiomyopathy or tachycephalic cardiomyopathy, and post cardiac surgery unable to maintain cardiac output, and failure to wean from cardiopulmonary bypass. So these are the indications. Other indications are bridge to recovery, like therapeutic strategy in small subsets. Principle is, and in maximum, most of the cases, LVAD is implanted for bridge to transplant. So the principle is mechanical unloading of LVAD, reverse the remodeling, and reduction in chamber size, improve the end diastolic pressure volume relationship. So contraindication to VAD therapy, any active systemic infection, major chronic risk for infection, high surgical risk for successful implantation, recent and evolving stroke and neurological deficit, fixed pulmonary or portal hypertension, intolerance to anticoagulant, morbidly obese patient, CKD with serum creatinine more than 3 mg per deciliter, restrictive cardiomyopathy, significant underlying psychiatric illness or lack of any support. So FDA, mostly FDA approved the mechanical circulatory support. The recommendation is class 2A recommendation for mechanical circulatory support. That is, class 2A means mechanical circulatory support may improve the patient outcome if used. So guideline is for initiation of mechanical circulatory support. So first thing is timing is very important. The sooner is the better, because once the end organ damage will set and the patient is neurologically obtunded, then recovery is poor only. So generally acceptable guideline is cardiac index less than 1.8 to 2.2 liter per minute per meter square, systolic blood pressure less than 90 mmHg, pulmonary capillary wedge pressure more than 20 mmHg, RA pressure more than 18 to 20 mmHg, evidence of poor tissue perfusion like oliguria, mental status changes, school extremities, and raised lactate levels. So common terminology for mechanical circulatory support. So BTR, that is bridge to recovery. So potentially reversible causes like acute MI, myocarditis, post-cardiotomy, cardiogenic shock. Then bridge to bridge, that is temporary mechanical circulatory support can be used to bridge for a long-term LVAD therapy. So bridge to transplant, which is patient who are eligible for heart transplant. Then bridge to destination therapy, that is recovery or transplant is not possible for that patient, so we will go for total artificial heart. Bridge to candidacy, then when eligibility is unclear whether this patient is fit for transplant or not, like patient with high pulmonary artery pressure and cardiorenal syndromes. Then bridge to decision, that is those who are patient with potential for transplant or recovery is unclear. Classification of ventricular assist device, that is based on pump mechanism. It is either pulsatile or continuous flow. Continuous flow further divided into axial, centrifugal, or mixed type. Based on location of pump chamber, it may be intracorporeal, extracorporeal. based on the ventricle supported, that is whether it supported left ventricle, right ventricle, or both the ventricle. And based on duration of support, it is short term, that is days to week, or long term, months to year. So this is a simple pictorial diagram for components of ventricular assist device. You can see the swing ring with cuff, then the inflow cannula which draws the blood, and there is a pump which pump it to the outflow cannula, and the blood is circulated through the body. Then come to the components of ventricular assist device. So electromechanical pump, that is placed parallel to the native patient circulation. Then inflow cannula that decompress the ventricular activity. In LVAD it is originated in LA or LB. In RVAD it is originated from RA or RB. In BiVAD it can originate in both atrium or ventricle. Pump provides the pulsation to the blood. Pulsatile pump is pneumatically or electromagnetically driven. Non-pulsatile pumps, there are continuous pump, may be axial, centrifugal, or mixed. So this is the diagram of centrifugal pump, and side of it is the axial pump with motor, axial motors, rotor. So pump is implanted subdiaphragmatically to the peritoneal position, preperitoneal position, intra-abdominal position, or paracorporeal position outside the body. Outflow cannula returns the blood to the either ascending aorta or main pulmonary artery. Then the controller which operates the pump by receiving and processing the information from it. Then percutaneous drive line which contains the control and power wire. It tunneled through skin of abdominal wall and connect the device to external portable driver. Types of mechanical circulatory support. Coming to the short-term mechanical support, this is a temporary mechanical support indicated in patient with cardiogenic shock, which are refractory to medical therapy. When rapidly achieved augmentation of cardiac output and reduction of ventricular filling pressures are required to sustain the life. So it is bridge to recovery. When used in the setting of medically refractory myocarditis or tachycardia cardiomyopathy, temporary MCS provide time for spontaneous recovery. When cardiogenic shock complicates the long-standing heart failure, temporary MCS can provide the time needed for patients and family member and physician to make critical decision about long-term MCS or heart transplantation. Examples are IABP, that is most commonly used short-term MCS device. Then extracorporeal life support like VV ECMO or VA ECMO. Impella is a axial flow pump which assist the LV to aorta. Tandem heart is it is also a short-term device with centrifugal type of pump which drive the blood from LA to aorta bypassing the LB. So this is the IABP pump. It's the most commonly used MCS device I told earlier. It contains a catheter with double lumen of 7.5 to 8 French catheter with a polyethylene balloon attached to it distal to the end, and with one lumen of the catheter attached to the pump used to inflate the balloon with gas. Helium is generally used because it is low viscous gas, so it can be used for inflating the IABP balloon. In IABP, timing of balloon inflation and deflation is very important. So inflation always start with the onset of diastole. So in the diastolic time that is exactly at the middle of the T wave when the balloon inflates just after the dicrotic notch, increase the aortic pressure. So it helps in better coronary perfusion. And the balloon deflates immediately after the onset of LV, rapidly deflates at the onset of LV systole. So it's produce a negative suction like effect. So it helps the aortic valve to open without impedance and decrease the afterload. So it provides better cardiac output. So it has seen that IABP increase the cardiac output by 20 to 30%, and it reduced the oxygen demand by 15% for the left ventricle. So this is the IABP console, and these are the augmentation, diastolic augmentation graph which shown how IABP help to augment the diastolic pressure. So, but IABP provides moderate ventricular unloading. It does increase the mean arterial pressure and coronary blood flow. But for IABP to work, it requires some level of LV function and electrical stability. Then come the ECMO support, extracorporeal life support, or extracorporeal membrane oxygenator. So it is two type. One is VV, another is VA ECMO type. VV is generally for respiratory support, and VA ECMO is for both cardiorespiratory support. So in case of biventricular failure, VA ECMO is the device of choice for patient in cardiogenic shock with impaired oxygenation, because it provides full cardiopulmonary support. This is the diagram of VV and VA type of ECMO. But it is also ECMO also a short-term mechanical artificial mechanical device for left ventricular support. So if there is with ECMO, VA ECMO, there is right ventricular failure also, we need RVAD, that is right ventricular assist device to function the biventricle properly. Then come to LV to aorta assist device, that is Impella. What I told before, it is a microaxial pump designed to pump blood from LV to the ascending aorta in series with the LV. So how it can support, it can be used both like RVAD or LVAD. So this is what the Impella is. So we will introduce the device retrogradely from femoral artery to the aorta, then into the LV through the aortic valve. Another short-term device is tandem heart, which is called, otherwise called percutaneous ventricular assist device, and that is it is a centrifugal pump, and it is the console is attached to the thigh of the patient, and it was introduced. It will be introduced from femoral vein to the RA, and through transseptal puncture it will go to the LA, and it will directly provide circulation from LA to the ascending aorta, bypassing the LV, so it gives rest to the left ventricle. Now coming to the long-term ventricular assist device. So there is three generations. The first generation, which was pulsatile blood flow type. Second generation is continuous axial flow type, and third generation is continuous centrifugal blood flow type. So there is a rematch trial, which this rematch trial is randomized evaluation of mechanical assistance and the treatment of congestive heart failure. So REMAC evaluate the use of durable implantable LVAD compared with optimal medical management for refractory chronic advanced heart failure. So this trial depicted that LVAD therapy reduced the mortality by 50% in control population, and compared to the optimal medical management therapy. But long-term LVAD therapy has some complications like stroke, infection, bleeding, device malfunction. So these are the complications and the risk benefit to be measured. So now come to the first and second and third generation LVAD, the comparison. If you see the size of first generation is larger size, but second and third generation is smaller size. Durability is less durable first generation, and second and third generation are more durable. Output determinants, first generation preload dependent, and second and third generations are pre and afterload dependent. Position of pump in first generation, it is intra-abdominal or pre-peritoneal in a pocket under the rectus abdominis. But second, third generation are intracardiac or intrathoracic. Pump capacity generally both same 10 liter per minute. Moving part, many moving parts in first generation, but in second generation it is motor only. Drive lines are thick and less flexible in first generation, but is thin and flexible in second, third generation. Battery capacity is short duration for first generation, but battery capacity is long for second and third generation. And thermogenicity, that is production of heat, is very high in first generation, which causes hemolysis and bleeding tendency. But in second and third generation, because these devices are mostly magnetically levitated, so frictional induced increase in temperature is very less. So these are the the pictures of first generation, second generation and third generation pump. In first generation we have Jarvik 7 Abiocore total artificial heart, then HeartMate 1. In second generation we have Jarvik 200, HeartMate 2, and third generation is HeartMate 3. The first generation pumps, that is HeartMate, CentriMag. Then in BiVAD category we have Berlin heart, and total artificial heart we have Jarvik 7 as first generation. Second generation I told HeartMate 2, and third generation is HeartMate 3. Really? So total artificial heart, this it completely support the both the ventricles. Severe biventricular failure, generally we used total artificial heart where transplantation is not feasible. So in this situation where we have to sever the both ventricle, and the conditions are cardiac tumor, aortic insufficiency of prosthesis, arrhythmias, LV thrombus, acquired VHDs. So currently approved FDA approval for biventricular support is bridge to transplant or bridge to destination therapy. So total artificial heart, the adequate criteria for considering total artificial heart is body surface area must be 1.7 meters square, more than, and cardiothoracic ratio is more than 0.5. Anteroposterior distance of thorax is more than 10 centimeter. LV diastolic diameter is more than 66 mm. Combined ventricular volume is more than 1.5 liter. Strict anticoagulation with warfarin, aspirin, and pentoxifylline. Examples I told: Abiocore total artificial heart, CardioVest total artificial heart, which is otherwise called SynCardia. So now we will come to some common complication of ventricular assist devices. That is acquired von Willebrand syndrome, which leads to bleeding risk because of the shearing stress. The Adam TS13 protein is activated, which cleave the von Willebrand factor. So there is development of bleeding tendency, which causes epistaxis and small bowel AV malformation and ischemia, bleeding. Then thrombosis risk, stroke risk is very high, but newer generation is low only. Hemolysis also is higher in first generation and very low in second and third generation. Infection, sepsis, for long-term VAD use, sepsis can induce. So if we are using LVAD then and not correcting the volume status and pulmonary hypertension of the patient, then there can be a chance of right ventricular dysfunction or failure, because if you see ventricular, that is called ventricular interdependency. dependency. This cardiac muscle work as a whole, and the RV functions, the RV output mainly dependent on two muscles. One is transverse muscle, which is mainly concentrated in the free wall, and oblique muscles, which helps in twisting motion of the right ventricle, which is present in the interventricular septum. So when there is LVAD, it always displaces the interventricular septums towards the left ventricle, which causes the left ventricle, that right ventricle twisting motion is decreased, and there is also chance of tricuspid regurgitation, which indirectly increase the right ventricular preload. So if we are not correcting the pulmonary hypertension and preload of the patient, then RV dysfunction can set with using of LVAD. Then closed aortic valve is there, so it can cause clot formation or stasis. Aortic insufficiency, there is lack of valve opening, LV decompression, small body size. This is the complication. And ventricular arrhythmia may occur during the LVAD therapy. So complications may be due to pump thrombosis, driveline failure or malfunction, increased LVAD afterload due to outflow graft kinking or displacement, and suck down, that is low preload, causes non-pulsatile VAD to collapse the ventricle, lead to acute pump thrombosis. Now coming to post mechanical circulatory surveillance, which we can do by clinical assessment, by seeing the peripheries of the patient, urine output, the mentation of the patient, higher motor function, and hemodynamic parameters. Then echocardiographically we can see the position of the mechanical circulatory support, is there any clot, and how the blood flow occurring through the pump. Then right head catheterization in the cath lab can also give us ideas about the pulmonary artery pressures. Is it severe pulmonary hypertension? Then sometimes we can adjust the dose of vasodilator, diuretics, and pump parameters to optimize the mechanical circulatory support. So when to stop mechanical circulatory support? So with any form of mechanical circulatory support, the device will eventually be turned off when there is a time for transplant or recovery, or to stop support in a patient who either no longer needed or wish to discontinue the support, in whom the continued function of mechanical circulatory support prevents their death from other causes like catastrophic neurological event or metastatic malignancy. So this is a graph showing 2 years patient survival with only medical therapy, which is 25%, but with LVAD and HeartMate 2, we can see the survival rate, 2-year survival rate is up to 74%. And no doubt heart transplant will give higher survival rate, that is 88%. So this is the simple diagram of algorithm how to decide which device to choose. So identification of the VAD candidate, is the patient is eligible for ventricular assist device. Then anticipate the duration of support. Then device indication we should think. Then commonly used device options. So is the patient with refractory heart failure on inotrope and IABP support, but still its hemodynamics not manageable, then we will go think of short-term LVAD. If it's a post-cardiotomy shock and we are thinking of bridge to decision or bridge to recovery, and in that case we choose short-term LVAD like tandem heart, CentriMag. For end-stage cardiac heart failure, which are candidate for transplant or destination therapy, we will go for long-term LVAD like HeartMate 2, Jarvik 2000 or HeartMate 1. So this is the algorithm for refractory heart failure management. So severe refractory cardiogenic shock, maximize medical therapy. If the patient's hemodynamic improve, yes, then continue the therapy. If it is no, then assess the salvageable potential or recovery potential of the patient. Is the patient is fit for mechanical circulatory support? If no, then we will go for palliative therapy. If the patient is fit for mechanical circulatory support, then we will definitely go for MCS therapy, and according to the indication, we will choose long-term and short-term therapy. So this is one inter-agency registry for mechanical assist circulatory support profile. It's otherwise called INTERMACS patient profile. This profile tells us whether to start mechanical circulatory support will be beneficial to the patient or the patient will deteriorate. So the catch is, higher the INTERMACS grading, the better is the outcome, and lower the INTERMACS profile, the poorer is the outcome. So INTERMACS profile more than 4 are good for ventricular assist device, and less than 4s are poor candidate with organ dysfunction and not going to recover with the LVAD therapy or BiVAD therapy, rather it worsens them. So here we can see INTERMACS profile. So this is the survival percentage of LVAD therapy. According to the years, we can see as the years increase, the survival rate decreases. So 1 month survival is 95%, whereas we can see 5-year survival is only 47% with LVAD therapy. So to conclude, it is the future of end-stage heart failure, improving quality of life, improving survival, either at stage bridge to recovery, bridge to transplant, or as a final destination therapy. Thank you so much.